So this is an uterus. And the fallopian tube. And here is the endometrial lining. So we know that is the endometrial, then there is the myometrial, then there is the myometrial, and then there is the outer layer is the perimetrial. Okay. So when accidentally this endometrial tissue is lost somewhere in the pelvis outside the uterus, we call it endometriosis. And if accidentally or due to some any other reasons, this endometrial tissue migrates to the muscle layer. If it is deep into the muscle layer, we call it adenomyosis. Okay, so adenomyosis means when this endometrial tissue is going deep into the myometrium, into the muscular tissue, like stromal, like the glands. Okay, normally these glands would be here. It is the endometrium. But when due to some causes, due to any other causes, these glands have migrated, it is deep into the muscle layer. Okay, then we call it adenomyosis. And when this, sometimes there are some tissues that grows in the myometrium, and when sometimes in this muscular layer there is some growth, okay, we call it as fibroid. And when this endometrial tissue is sometimes deposited outside the uterus in the pelvis, we call this endometriosis. Okay, so that is the basic difference between, in the structurally way, that is the basic difference between endometriosis, then adenomyosis, and then fibroids. Right. So what is endometriosis? It is the migration or the placement of endometrial tissues outside the uterus. So this endometriosis is estrogen dependent. Remember this thing. It is estrogen dependent. Estrogen dependent. And this is mostly found in nulliparal and unmarried. So I'll tell you why. Okay. So first thing that I told you, it is estrogen dependent. It is present in nulliparous. It is present in unmarried. Now this, if I take some pinch of estrogen from here and put it here, endometrium, if I take some pinch of endometrial tissue from here and put it here, so what will happen? Wait, some people are coming. So this endometrial tissue will also react according to this endometrial tissue. So whenever there is menstrual bleeding, whenever there is menstrual bleeding, they also will bleed. Okay, so that is the basic thing of endometriosis. They will also bleed along with the other thing, because they are all, this whole endometrium, whom do it respond? This endometrium is responding to estrogen. It is continuously affecting the endometrial tissue to grow, and then during menstrual cycle there is bleeding. So totally this endometrium is dependent on estrogen. So whenever this endometrium is located outside, what we call endometriosis. So whenever this menstrual bleeding occurs, these tissues, these endometrial tissues which are located outside, they can also bleed. That is the problem. Okay, they can bleed and cause a lot of adhesions. We'll come to that. Now look at the nullipara. So nullipara means they are no children. So, and one more thing, they are found in reproductive age group. So one who is in the reproductive age group, like young women from 18 to 40, they are in the reproductive age groups. Nullipara means never been, no children. Unmarried means basically no children. Okay. So what happens here? Why they are close in a group? Because they are more exposed to estrogen. Like for example, if someone got pregnant, during pregnancy, that 9 months, there is high amount of progesterone. Yes, estrogen will be also high, but progesterone will always make it, the estrogen activities more and more suppressed. So that's why pregnancy is said to be a good treatment for endometriosis. So reproductive age group, nulliparous, unmarried, what are the common thing between them? The common thing is that they are all are in a high estrogen group. That's why they are more common, because they have high estrogen. Okay, young women have high estrogen than a menopausal woman. And the reproductive age group or nullipara means no children. So not even she got one time pregnant. So there was no halt of that estrogen level, because during pregnancy there is no menstruation, no ovulation. So whole 9 months is dominated by progesterone. So estrogen effect was down. So that's why they are more prone to endometriosis. Who are more prone? Reproductive age group or nulliparous or unmarried group. They are more prone to endometriosis. Now what is endometriosis? Coming back. Now there are many theories about endometriosis. Okay, there are many theories. So most acceptable theory is the Sampson's retrograde theory. It's called Sampson's retrograde theory. Retrograde theory. So according to Sampson's retrograde theory, that when there is menstruation, there is also reversal of the menstruation blood, and from with the blood, we know in the menstrual blood there is endometrial tissues also. So this endometrial tissues is coming out of this. That is Sampson's theory, and it is most widely accepted. And why it is widely accepted? Because it does make some sense. I'll tell you why. Okay. Now, what are the common sites of endometriosis? Where are the endometriosis commonly located? Okay, most common site is the ovary. Okay, so most common site is ovary. Then pouch of Douglas. Pouch of Douglas. Then uterine sacral ligament. Uterine sacral ligament. So I will tell you how they are into this incorporated into this theory. Look, so let's assume that there is retrograde menstruation. So menstrual blood along with endometrial tissues is falling down from here, from the open fallopian tubes. Let's imagine that situation. Now what is here? Here there is ovary. Okay, what is here? There is uterosacral ligament. So from the uterus, ligament is going to the sacrum. Okay, and what is this gap? There is the peritoneum. The peritoneum that is all included. This peritoneum is the fold. It coming into the between the uterus and the rectum. So let's say this is uterus, anteverted uterus. Then there is the urinary bladder, and here is the rectum. So peritoneum, when the peritoneal fold, peritoneum it covers all the organs. So there is a peritoneal fold here. So I am trying to say this space. Okay, this space. So it's a bag. It's a bag kind of thing. It's a bag. So there is a bag of peritoneum. So if I now, so let's modify this fallopian tube. So let's say there is a retrograde menstruation. So if there is retrograde menstruation and there is falling of blood from here with endometrial tissues, where it will fall down? It will fall here, it will trickle here. Right? That's number one. That's why ovary is the most commonest site of endometriosis. It will fall here. Then where it will fall? It will fall in the pouch of Douglas. This is the pouch of Douglas, which is this I am talking here. This is the pouch of Douglas, the peritoneal fold between the rectum and the uterus behind. And where else it will fall? It will fall on this ligament, uterosacral ligament. That's why they are the most commonest sites for endometriosis. Though they can be found in many other places in pelvis, but most common place is where if you take some endometrial tissue and throw it from the height from this fallopian tube, so it will fall in the ovary, it will be scattered in the pouch of Douglas, it will be scattered all along the uterine sacral ligament. That's why they are the common sites of endometriosis: ovaries, pouch of Douglas, uterine sacral ligament. So these are the most common. Apart from that, they can be present anywhere actually. They can be present anywhere. So that's why mostly my personal view, that Sampson theory of retrograde menstruation is most widely accepted. Apart from that, there is other theories like coelomic metaplasia, and there's immunological theory. So because of these reasons, there are many other theories, coelomic metaplasia, immunological. So because of these reasons, endometriosis is more commonly in ovary, in pouch of Douglas, uterine sacral ligament. So that's why this retrograde theory of menstruation is very widely accepted. Okay, just to recap here. So if we throw little bit of menstruation and or an endometrial tissues from here, so it will be falling on the ovaries, it will be falling on the pouch of Douglas, it can fall on the uterosacral ligament. So this ligament is going from uterus to the sacrum, behind. Okay, behind. It's not actually sideways, it's behind. From uterus to the sacrum. So that's why these are the three sites. And what are the rare sites? Rare sites can be scar. So scar is the commonest of rare sites. Okay, so that explains the direct implant. It explains the direct implant theory. Direct implant. Now, if you are doing a cesarean section and during that operation of cesarean section, you might take some endometrial tissue and implant it directly over there during your operative procedure. Okay, there can be this type of things can happen. So that's direct. So if the means if I take some endometrial tissue and put it on your scar, so what will happen? In few weeks there will be development of some nodules, because if I put anywhere, so if I put anywhere some endometrial tissues, they respond to estrogen. So every month when estrogen goes up, they will also proliferate. They will also proliferate. So with estrogen, they will also proliferate. And when estrogen goes down, they will also go down. And this endometrial tissues, what they have inside, they have stroma and glands. They have glands, blood vessels, stroma, everything. They proliferate with everything like endometrium in the menstrual cycle. So when this bleed, they also bleed. So everywhere there is endometrial tissue, they can bleed. That's why in endometriosis, when diagnostic laparoscopy is done, most of the portions here are covered with blood clot. This blood becomes clotted and they adhere. They pull everything together and there is adhesion. There's like it acts like a glue when it heals. Okay. So this endometrial tissue, remember this is a non-cancerous lesion. But if the endometrial tissue anywhere, because they respond to estrogen. So when estrogen goes high, this endometrial tissue also proliferates. And when estrogen goes down, they also goes down. And when it bleeds, they also bleed. So that is the problem. Wherever they are, they will respond to estrogen. So common of the rarest site is scar. So it has been also found in pleura. Okay, and also in nose also. That is one of the rare instances when it was found in nose. When one lady, every time she has menstruation, she also bleed from nose. She has epistaxis. So that time, then she was investigated and found there some endometrial tissue. So it can also spread by hematogenous route. Like if somehow this endometrial tissues go inside the blood vessels, they will travel through the blood and go to the distant organs. And then every month they will also bleed along with this endometrial tissue. That is the problem. So that is endometrial tissue. Alright. So out of these extragenital sites, now these are all genital. So in the peritoneum, they can lodge anywhere. Okay, they can lodge anywhere apart from the commonest cause. But out of this, which is the most commonest extragenital site? So most commonest extragenital site is the sigmoid colon. So this is the large intestine, and so this is the sigmoid colon. So most commonly endometriosis can occur here also. It can grow also in sigmoid colon. So most common extragenital site is sigmoid colon. Most common site of endometriosis in the peritoneum, inside the peritoneum, is the ovary. After ovary is pouch of Douglas. After pouch of Douglas, it is uterosacral ligament. I already explained it to you. Okay, next. So Then what are the consequences of endometriosis? So what are the consequences? If there is endometriosis, what will happen? So look, now this is the uterus. This is the uterus which is anteverted, and here is the bladder, and here is the rectum. Okay, so uterus, this is unibladder, and this is rectum. So uterus is anteverted. It is an anteverted position, and here there is a pouch of Douglas here. So if there is endometriosis here, what will happen? If there is endometriosis here, so endometriosis can be here in the pouch of Douglas. Yes, we know that it can be here. So it can lead to what? When endometriosis means what? There is endometrial tissues which will bleed like menstruation. Regularly every month they will also bleed. So blood will be deposited here. So very soon the blood will form clot. Then this clot can be converted into cyst. It will be covered, okay, and or else what can happen? All these tissues, okay, the whole uterus. So there can be some. What will happen? It will act like when it heals. There can be what we call adhesions. So if there will be adhered, so it will, what will happen? The uterus is normally anteverted. It will pull the uterus back. So as a result, as uterus is normally in this position, now uterus is in this position. What we call as retroverted uterus. So what are the consequences of endometriosis? Number one, there can be retroverted uterus. There can be cyst. So if it is lodged in the ovary, suppose this is in the ovary, there is endometriosis. Now endometrium has went here. So they will be turned into cysts very soon. So they will turn into cyst. So number two is cyst. Then often there will be blood clot here. Every month they will bleed. So they can bleed here. And when they will bleed, they will form blood clot. So the clot will soon, because of presence of hematocydin, there is a pigment, they will soon become brown colored because of the clot. Then brown colored. As a result, the whole cyst and the whole covering of the ovary, as a result, the whole ovary will look like dark brown or chocolate colored, which is called as chocolate cyst. Remember, chocolate cyst is not because of eating of chocolates, okay? This is because of endometriosis. It is a result of endometriosis. In some books, it is also mentioned as endometrioma. So what happens? Here it is cyst, there is blood. In the blood, there is hemocysteine. So it turns into all in chocolate colored, brown colored inside. So the whole ovary may look like brown colored in laparoscopy. And that's why we call it chocolate cyst. Then what are the consequences here? Number one consequence is there is formation of, there is retroverted uterus can occur because of adhesions. So this is also a consequence. This is also consequences. Adhesions can occur. Retroverted uterus. Then formation of cyst. Plus there can be cyst, can be multiple cysts, single cyst inside the ovaries. Then there is chocolate cyst. And there is then bleeding. And overall what happened here? The whole architecture is lost. It is damaged. So distorted architecture or distorted anatomy of this uterus or the genital organs here. So not genital organs, sorry, distorted anatomy of the uterus. The whole thing will be distorted. Now one more thing, one more common thing that I forgot to mention is that endometriosis is also found now in causes, okay? So I forgot a little bit about causes. So these are the effects in summary. So there are chocolate cysts, bleeding, retroverted and adhesions. Now what are the causes? So causes which are, firstly there is a genetic background. Genetic background is there. There is some gene which is defective. It has been in a lot of research nowadays. There is a genetic background, and that's why first degree relative are having 7 or 10% more chance than other population. Means first degree relative means if your mother is having endometriosis, then also you can have, you have 10% increased risk. Okay, so we mention it as the first degree relative. Then what are the other causes here? It is very commonly associated with Mullerian anomalies. Remember that. Mullerian anomalies. Now what is Mullerian anomaly? Basically, in the embryological stage, there is two tubes which are called Mullerian tubes. Embryologically, there are two tubes which are called Mullerian tubes. Okay, so the upper end of the both of the Mullerian tube, they gradually, when the baby grows, when the fetus grows, they become fallopian tube. Upper end, gradually. And the lower end, it fuses. Okay, it fuses and forms the uterus. It fuses and forms the uterus. So any defect in Mullerian tube during that embryonic development can lead to lot of anomalies like bicornuate uterus, single horn uterus. There may lots of congenital uterine defective. So this congenital defective, when there is not properly joined, not properly fused, then it can always stimulate more and more retrograde menstruation discharge. Retrograde menstruation discharge. So that's why any patient with Mullerian anomalies, they always have high chance of endometriosis, because this congenital defect, it makes the development of endometriosis more. Okay, there is high chance because already there is defective. So if there is some blockage here, so obviously the menstruation blood will go backwards. So there is a high chance in Mullerian anomalies. That is also one of the things. Okay, so moving to next. What are the clinical presentation? So clinical features. So clinical features, remember there is pain is the ultimate thing here. The painful menstruation, heavy menstruation is ultimate. The pain with dysmenorrhea and overall infertility. So there is severe pain during menstruation, and this pain is so high that it can lead to even dyspareunia. It can lead to into dyspareunia. So painful sexual intercourse. So dyspareunia. So why there is so much of pain? Now what happens here? Now let's imagine this. So let's imagine there is endometrial tissue here. Now this endometrial tissue is located in the peritoneum, or it is in the ovaries, or it is in the uterosacral ligament. So whenever there is this endometrial tissue is there, there is always inflammation. So in endometriosis, there is inflammation. Inflammation means our antibodies will react, our immune system will react to the presence of this endometrial tissue somewhere inside the peritoneum. So they will release some inflammatory markers. You know the most three common markers are tumor necrosis factor. So what will happen? There will release of tumor necrosis factor alpha, interleukin 1, interleukin 6. These are our inflammatory markers, mediators. So whenever there is endometriosis somewhere, our body will react by releasing inflammatory markers like tumor necrosis factor alpha, interleukin 1, interleukin 6. So these things will be stimulating the nerves present inside the peritoneum. They will stimulate always the peritoneum. So they will stimulate the nerves in the peritoneum, and that is causing severe pain. And remember, there is in clinical features, don't forget to mention, there is always a kind of subclinical peritonitis, because this endometrium, this endometriosis, when these endometrial tissues, often they are lodged very close to peritoneum, very close to peritoneum. So they can often cause subclinical peritonitis also. So above and all, first thing is that it can cause severe and severe pain. And this pain depends upon depth of invasion. So more is endometrial tissue, more will be pain. Okay, and this is caused because of inflammation. So inflammation is the basic pathophysiology in development of endometriosis. Okay. Then what else? There is, so pain is the number one. Number two is, so along with pain there will be dyspareunia, inflammation, TNF, and what else? It can cause also development of pelvic mass and adhesions. So pelvic mass and adhesions are very, very common here. So there can be, when these are growing more and more, with growing age, every menstruation, there is bleeding, there is clot. That's why it's called as every menstruation is a threat here. Because in every menstruation, this endometrium is bleed. And when the bleed, there will be clot, there will be adhesions, and they can form a pelvic mass. Where this pelvic mass can be found when you do paravaginal examination, you can feel that mass in the posterior fornix. Okay, and you can feel like a nodule. So pain, pelvic mass, and third is infertility. So why there is infertility? So infertility, and why? So first thing is that this architecture is not like any other dish. So in endometriosis there will be loss of architecture, the loss of anatomy is there, loss of architecture, because there will be loss of architecture and there will be so much of adhesions. Now remember one thing, this when there is endometriosis, though there is endometrium may come from here and trickle from down here, but there is no fallopian tube involvement. So when we check in infertility, the fallopian tube is completely okay, but the problem is in the other sides. So because of this growing, remember I told you every menstruation is a threat. So in menstruation, every time endometrium there is bleeding. So as well, the endometrium located outside the uterus, they can also bleed, and they can form clot. So along with clot, there is a next thing is happening in the adhesions. So with adhesions, everything will be pushed somewhere here and there. So there is loss of architecture, loss of anatomy of this whole thing. So the tubal motility or the migration of the sperm or the catching of the ovum is very difficult here. Now remember, this fallopian tube is here, and every month during ovulation, then one egg is going here. So fallopian tube is here and one egg is going here. So there is a big challenge here. The fallopian tube must be normal here because it has to catch the egg. It's not that egg don't go directly into this tunnel. Egg has to be catched. So if the fallopian tube is not motile and the whole architecture is lost, it is bent or it is adhered or something, it cannot catch the ovum. So that is the reason, that's why, because though ovulation can be there, but if the ovum cannot be catched by the fimbrial ends of the fallopian tube, there cannot be any fertilization. So loss of architectures, adhesions, and failure to trap the egg, failure to catch the ovum. That is another thing that can happen. If when the fallopian tubes are stiff, because of some pulling from somewhere, because of adhesions, and they cannot catch the egg, then infertility can occur. Other than that, those, because it is basically, yes, architectural loss, and but as I told you, fallopian tube does not cause much effect to the infertility. It is always normal. Plus there is an ovulation. So main thing in the infertility is an ovulation. There is no ovulation. Why there is no ovulation? Now look, this follicle has to release one egg every month. Now what happens in endometriosis? There is endometrial tissues. Now when there is endometrial tissue, there will be also some inflammatory markers, some inflammatory mediators. So these inflammatory mediators like cytokines or other immune cells which are trying to counter this endometrial tissue, they will also suppress the follicles. So during that time the follicles will not be grown if there is lots of endometrial tissue. Though it depends upon the depth of invasion, how much endometrial tissue is inside the ovary. So when the endometrial tissues inside the ovary grows, and you imagine they are bleeding every month, okay, so and there is inflammation also there. So whole thing is like a battlefield inside the ovaries. During that thing, when there is a battlefield going on here, these follicles cannot grow, cannot mature, cannot release an egg, obviously. So failure to catch the ovum and failure to ovulate, these both things, one is that there is ovulation is depressed or suppressed. Next thing is that failure to catch. These two things leads to multiple factors, they leads to infertility. So that is why in endometriosis there is pain because of stimulation of the nerves plexus by the inflammatory cells, and second thing that there is infertility. So what are the main causes of infertility? Number one is anovulation. There is no ovulation. When the endometriosis grows, there is no ovulation. Number two is that the failure to catch the ovum is also an important factor. And third thing is that loss of architecture because of adhesions. The whole anatomy is lost because of adhesions, and then it cannot, even then if catch, there is because of anatomy, it is so divergent and so distracted that it may not be able to travel and implant. That is also one of the features. So there is multiple features which can cause infertility. Okay, next is diagnosis. How will you diagnose? So in diagnosis, yes, we will do all the blood tests, everything. Now if there is cyst in the ovary, okay, if there are some cyst in the ovary, yes, it can be diagnosed by ultrasound. But if there is endometriosis is present over the pelvis, like this is pelvis, so if endometriosis is here inside the ovaries, yes, you can diagnose by ultrasound. But if endometriosis is here or here in the uterosacral ligament, sometimes you will not find anything in ultrasound. It can be diagnosed only by laparoscopic examinations. So ultrasound is one of the features. Laparoscopy, diagnostic laparoscopy is also one of the features. And plus don't forget to do pelvic or your paravaginal examinations. So in the front is anterior fornix. This is the posterior fornix. So when you are putting your finger, and when you go this way, you'll feel that there will be some nodule here. So these nodules can be felt when you put your finger in the posterior fornix. So paravaginal examinations, ultrasound, diagnostic laparoscopy, by all these methods we can diagnose. So remember one thing, when you do a diagnostic laparoscopy, it should be always diagnostic plus therapeutic. Now it cannot call a patient twice. So you have to make the patient understand that if we find something, we'll remove it at that same moment. Okay, so laparoscopy, when you take the consent of the patient, you have to do it diagnostic plus therapeutic laparoscopy. You should not open the abdomen twice, once first time to see and confirm, second time to go and operate. No, not like that. So this should be diagnostic and laparoscopic therapy. Plus, make sure you take the endometrial tissue and send for histopathology. Ultimate is histopathology, but we cannot wait for that. You have to do diagnostic and therapeutic laparoscopy. So what is the treatment now? What is the treatment plan? So treatment, we have two parts in the treatment. First, we have to relieve the pain. Next, we have to treat the infertility. So how will you relieve the pain? So there is so much of pain that causing dysmenorrhea, lots of blood is going out, okay, and it's causing day-to-day activities very impossible for the woman, okay, one who is working especially, or even someone is housewife, they have to do all the normal household chores. So when there is pain, everything is shut down. It's very, very irritating for the subject. So how to release the pain? So first thing is, if there is mild pain, we can go for NSAID group of drugs. We can give some painkillers, NSAID like ibuprofen. We can give this. So next preferable drug is, as we discussed yesterday in the contraception class, what are the benefits of oral contraceptives? So next is OCP, oral contraceptive pills. Now, as you know, oral contraceptive pills has estrogen, that is estradiol, plus progesterone. So we'll use this drug mainly as a progesterone effect. So why we give progesterone? Now, because progesterone, we know endometrium. So we'll choose a tablet where we'll choose a tablet where estrogen dose is very low, okay, and we'll take a high dose of progesterone. Now, why this progesterone? Why we give progesterone in endometriosis? So we know this, it stabilizes the endometrium. This progesterone will stabilize the endometrium. And remember, when you give OCP, when you give oral contraceptive pills, we know there are 21 hormonal tablets and 7 days of free hormone period. So in this case, when you are using OCP for the treatment of endometriosis, you will not use what is called free period. So it will be straightforward for 3 months. There is no free period like of 7 days iron tablets, no, nothing like that. It will be straightforward. 90 days of means 90 OCP pills. So it will be continuous. So what we are trying to do here? So when you are giving continuous progesterone influence, so what's happening here? If you are giving continuous progesterone influence, it can cause amenorrhea. You can say it's stopping the menstruation. Or you can say a menopausal like thing. So there are some side effects which comes when you are forcefully inducing menopause here. Okay. So what happens? You are giving progesterone for straight 3 months without any free period. Now remember, there is no free period, because free period means you are stopping the progesterone. Once you stop the progesterone, there is menstruation. We know that in the menstrual cycle, this is estrogen phase and progesterone phase 0-28. There is the LH surge. So what happens in progesterone period? When the progesterone goes down, menstruation occurs. So like in pregnancy, what happens in pregnancy? This progesterone remains elevated. So you are giving so much of progesterone tablets here, progesterone here. So in the blood, progesterone remains high and elevated. And what is causing? Is causing amenorrhea. That's why this tablet is also chosen when sometimes some patients will come to you that I need to do some work, I need to travel, I need to go there, I need a 3 months break, my marriage is coming, I need a stage of amenorrhea. People will demand that. So how do you induce the process of amenorrhea? So you will induce the process of amenorrhea by keeping progesterone high, by giving OCPs. That's the simple thing. You are giving OCP which has got high progesterone, so progesterone will run in the blood, it will remain high. So if you stop for a free period, like when you give for contraception, if you stop the progesterone for 7 days, what will happen? Progesterone goes down, endometrium goes down, and there is bleeding. So when we give a high dose of progesterone, like by oral contraceptive pills, straight for 3 months, okay, then we are creating a situation of amenorrhea in the patient. And that time there is amenorrhea, means what? Endometrium is not bleeding anywhere. So wherever the endometrium is, whether outside uterus, inside uterus, wherever it is, it's not bleeding anymore. So it is healing the endometriosis, because there is no further formation of blood clot. There is no further formation of adhesions. Because moment endometrium bleed, whether inside or when it's outside, there will be adhesions, there will be blood clot, there will be inflammations. So when you are reducing all those inflammations, so you are doing, you are decreasing the pain. So this is a long-term treatment. You cannot say that the patient is having severe pain today, endometriosis, and you are giving OCP. So don't expect that the pain will go by in next 2-3 hours. Yes, you have to cover it NSAID. But when a patient is presenting with severe pain since 2 months, 3 months, we cannot give painkillers for a long time. Okay, so we'll try this OCP in patients who are having long time. Since 6 months he is having pain every day. Since 7 months she is having painful menstruation, and pain is so severe she cannot do anything, and it's almost happening every day. Then we try these drugs. So OCP is always the best option. That's what we are doing in OCP. We are keeping the progesterone level high, because we know progesterone goes down means menstruation will occur. So we're totally keeping the whole area dry. So no menstruation, no bleeding, no formation of clot, no adhesions, and no inflammations. So inflammation will subside. When inflammation will go down, pain will subside. So that is the way we treat the pain in long-term pain or chronic cases of dysmenorrhea, by simply giving OCPs. That is the role of OCP here in relieving the pain along with NSAID. What is the third drug that is very also common is gonadotropin analogs. So this drug is also used very commonly. To understand this drug, you have to understand the ovarian axis. Okay. So what happens? This is the pituitary gland, which release LH and FSH. We know that. And pituitary gland is affected by hypothalamus. So every month hypothalamus release gonadotropin releasing hormone, and it goes to the pituitary gland. Okay, it goes to the pituitary gland, and there is a receptor in the pituitary gland. So this gonadotropin hormone is released in pulsating manner. It's releasing pulse. So some amount of gonadotropin hormone will come. It will stimulate the pituitary gland. It will stay there for 2 to 3 minutes. So half-life is very short. So it will stay. So let's say there is a gonadotropin hormone came. It stimulates the receptor, and when the receptor is stimulated in the pituitary gland, it is secreted LH and FSH. Right? So it is always secreted in a pulsating manner. It comes in a pulse. And after a few minutes, this receptors it dies off and effect is gone. Now here what happens if we give a synthetic gonadotropin releasing hormone from outside? So we are now giving a tablet which has gonadotropin releasing hormone, okay, and it is long acting, not short acting like that. So if we give it from outside, so let's say you have given gonadotropin releasing hormone tablet from outside. So this tablet is long acting. We are not making it short acting like normal natural hormones. We are giving a long acting. So when you are giving the tablet, this drug will sit on the receptor for a longer time. It will sit on the receptor for a longer time. So what will happen? First there will be initial flare. We call it response as a initial flare. Initial flare. So first of all, when you give gonadotropin releasing hormone analogs, what will happen? It will go and attach with the receptor. And what will happen? There is increase LH and FHS. Increase, 10 times increase. It can increase up to 10 to 20 times sometimes. Okay, depends upon your dose. So suddenly LH and FHS will increase. But very soon, because of continuous stimulation, because of continuous stimulation, these receptors will become insensitive. So what we are doing in a long run, we are making the receptor insensitive. So because of continuous attachment here what is happening here it is receptor insensitivity. Like very commonly, let's say you are staying home and you have a guest here who you like your guest very much. So when he came to your home for first day, you will cook many things. There will be big recipe for that. The whole dining table will be covered. But when he is there and staying with you for a long time, for a period of 1 month, 2 month time, then I believe after 2 months, 3 month time, you are not going to entertain him anymore. So whatever you eat, you will just give it to him. Or sometimes you may not be liking to give it to him because you are so irritated. So that's called, why happened? Because you will become insensitive to him. You are becoming insensitive because of continuous presence. Same thing happens here. So when this hormone analogs, this medicine we give, which are long acting, they will just sit on the receptors. And when they are sitting on the receptors, yes, there will be initial flare. There will be a big buffet first. Lots of LH and FSH will increase in the blood. But gradually, there will be receptor insensitivity. So what will happen? Receptor insensitivity means this pituitary gland will no more secrete LH and FSH. So they will fail to respond because LH and FSH can be secreted by pituitary gland only when there is an influence from the hypothalamus. When there is an influence by gonadotropin releasing hormone, then only they can secrete. But if this receptor cell become insensitive, they cannot secrete LH and FSH. So if the LH and FSH drops, now where does LH FSH go? They stimulate the ovary. What they do, the LH and FSH, they stimulate the ovary. So if I am blocking the LH and FSH release from here, so there is what is happening here. Ovary is not releasing any sort of estrogen hormone. No estrogen is coming out of ovary because of ovarian suppression. So you are creating a stage of ovarian suppression. So you are suppressing the ovary. So ultimately again you are creating a false menopause like situation when estrogen hormone is totally down. So this is the situation when you are giving gonadotropin releasing hormone, the person's estrogen hormone totally goes down because you have suppressed the ovary by blocking the receptor in the pituitary gland. So you totally suppress the ovary. So what will happen if you suppress the ovary? If you suppress the ovary, you have blocked the ovary, means ovary cannot secrete estrogen without influence of LH and FSH. Now LH and FSH has to come from pituitary gland. Now pituitary gland cannot act without stimulation from gonadotropin releasing hormone. So now you have blocked the receptor. And all the receptors are becoming functional. They have desensitized. They are not activating. They are not interacting with the gonadotropin releasing hormone. So the condition in the body is that there is total lack of estrogen. Estrogen hormone very goes down. So what will happen in that situation? You are creating a scene of menopause. Yes, it is good situation for endometriosis. But in the long run of life, you know what will happen. And when endometriosis goes down, means you are creating a scene of menopause, means what will happen? There will be hot flushes, all these menopausal symptoms. Plus, very importantly, don't forget there can be osteoporosis. So that is the side effect of gonadotropin releasing hormone analogs. You are creating a scene of osteoporosis in a young woman who is a nullipara, who is unmarried. Okay? So that's why gonadotropin releasing hormone, yes, it is very beneficial. It is very active and highly beneficial for treatment of endometriosis, but make sure you don't use it for more than 6 months. So once you go beyond 6 months, it can cause osteoporosis. And make sure you have to give some estrogen supplement also, so that they don't have endometriosis. You have to support it from outside also to make the bone survive. So that is the reason why gonadotropin releasing hormone should be used very cautiously. It is used every day by the gynecologist. Yes, but you have to be very careful because it has a lots of beneficial effect, but it can cause a scenario of osteoporosis. Remember that. Other than that, so we know that gonadotropin hormone, all the analogs, is do things. So what else it do? It can also, yes, it can create osteoporosis like symptoms. So we'll cover it. And yes, you have to give estrogens support if needed. So that's why, yes, as I told you, it is not for more than 6 months, and this is very, yes, the question is that, so what we are doing here, we are treating the patient with gonadotropin releasing hormone. We are treating the patient with gonadotropin releasing hormone analogs. Okay, so we are completely suppressing the ovary. So ovary is completely suppressed. So no estrogen. There is a estrogen level goes down. That's why the same philosophy, same logic is used when there is a tumor that is, or when there is a growth, or there is a tumor that is dependent upon estrogen. Look, like what happens in fibroid? What happens in fibromyalgia? In fibromyalgia, there is a muscle tissue. There is a big muscular growth. This muscular growth always grows when there is high estrogen. So with growing estrogen, because this is a fibromyalgia is also estrogen dependent. So when estrogen grows, this fibromyalgia or the fibroid of the uterus, it also grows. So this treatment can be also used for treatment of fibromyalgia. So in the fibromyalgia also, gonadotropin releasing hormone analogs can play a good role. Similar thing in the adenomyosis. Endometrium has migrated to the myometrial layer, okay, and causing a lot of infertility and other problems. In that thing also, we have to suppress the endometrium because endometrium will bleed there also. Okay, so that thing also you can use. So gonadotropin releasing hormone analogs, it can be used in fibroid or fibromyalgia. It can be used in adenomyosis, and most importantly, it is used in endometriosis, because all these three things are estrogen dependent. Okay, so we are creating a situation here, ovary is not supplying any estrogen. So that is the basic motive of treating of what is called endometriosis. So next, what else you can give? So apart from that, you can give progesterone only tablets. You can also give progesterone only tablets. So high dose of progesterone only tablets can be also chosen. Okay, so there is some progesterone intrauterine device also, which is upcoming in the market, called Mirena. This is an intrauterine device, progesterone, which releases progesterone. So you can use this one also, and aromatase inhibitors can be also used. So remember this aromatase enzyme from a physiology background, that this testosterone can be converted to estrogen in the body. Estrogen is mainly supplied from testosterone, because estrogen is converted from testosterone with the help of an enzyme called aromatase. So when you are giving a drug called aromatase inhibitors, you are blocking this conversion. So ultimately estrogen level will go down. So that is also one mode of treatment for endometriosis. So some old treatment of endometriosis are there, like danazol, which is, so danazol was used in the last decade a lot, okay, for treatment of endometriosis. But the main problem with danazol is that it is derived from testosterone, and that's why it has androgenic side effects. So remember, danazol is one of the commonest cause for acne and hirsutism, because it has androgenic side effects. So nowadays danazol is not being used because of so much of androgenic side effects, growing of hair, hirsutism, acne, all those things. So preferably we can go for OCPs is the best way, or else you can go for progesterone only also, not a problem, or else you can go for gonadotropin releasing hormone analogs. And overall, you can go for diagnostic laparoscopy. That is the best if someone is married and want to get rid of pain. Then diagnostic laparoscopy is very, very useful. The last choice, if someone has completed the family, and no more want to conceive, and she's undergoing lot of dysmenorrhea, okay, lot of bleeding, lot of dysmenorrhea, and lot of adhesions, all those problems, then finally you can go for hysterectomy with bilateral salpingo-oophorectomy. So this thing will be coming only when the patient has completed the family and they don't want to conceive. Okay, then we can go for hysterectomy. Otherwise, it can be treated with OCP. So this is not so favorable, because it can be treated by OCPs. It can be treated by gonadotropin releasing hormone analogs. Alright. So surgical treatment, yes, hysterectomy or bilateral salpingo-oophorectomy, because you can go for a lot of surgical options, is called laparoscopic treatment. So if the patient is like young, we know the most common are young groups and still not married, want to conceive in future, so we'll go for mostly laparoscopic treatment. So we'll remove the cystectomy. So if cyst is more than 4 cm, if the size of the cyst is more than 4 cm, then we can go for cystectomy. But if cyst is less than 4 cm, then it is very dangerous that you put your instrument, it can hurt the neighboring structures. So if cyst is less than 4 cm, then usually is the drainage. So when you are doing laparoscopy, you have to, before laparoscopy, yes, if the cyst is in the ovary, now you want to take a decision. Yes, first we will do ultrasound. In the ultrasound, we will measure the size of the cyst. If the cyst is more than 4 cm or around 4 cm, then you can go for cystectomy. But if the cysts are small, multiple, and small cysts, then the cystectomy is not preferred. Then you have to go to drain the cyst and then ablate. Then with whatever, we'll check all the pelvis, we'll check everywhere in the pelvis if there is any endometriosis. Okay, we'll check everywhere in the pelvis. So we'll check everywhere in the pelvis. So suppose there is uterosacral ligament, we'll check the pouch of Douglas. So wherever the endometrium tissue is there, we'll take the laser or we'll make it cauterized, or what we'll do, we'll do burning or called ablation. So that will come in the package. So yes, we'll remove the cyst and then we'll inspect the whole pelvis. Okay, if there wherever the endometrial tissue, we'll just ablate it. There's ablation, or we call fulguration of deposits. Fulguration of deposits are done. So medical treatment, yes, we can give painkillers, OCPs, gonadotropin releasing hormone analogs, progesterone only tablets, then danazol you can give. Then coming to surgical treatment, yes, the diagnostic laparoscopy plus therapeutic laparoscopy.